Welcome to the Epidemiology and Prevention of Vaccine-Preventable Diseases webinar series, also known as the Pink Book. I'm Dr. Raymond Strickus, your moderator for today's program, coming to you today from Atlanta, the Centers for Disease Control and Prevention. For today's program, you need primarily an internet connection, which will connect you to the visual and the audio portions of the program. The learning objectives for today's program include ability to describe the different forms of immunity, describe the different types of vaccines. For each vaccine-preventable disease, identify those for whom routine immunization is recommended. For each vaccine-preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice. And implement disease detection and prevention healthcare services such as smoking cessation, weight reduction, diabetes screening, blood pressure screening, and most relevant to today's program, immunization services to prevent health problems and maintain health. Today's agenda includes, in the Epidemiology and Prevention of Vaccine-Preventable Diseases webinar series, or the Pink Book, Varicella and Zoster diseases and vaccines, presented by Joellen Walicki, who's a nurse educator in the Communication and Education branch in the Immunization Services Division of the National Center for Immunization and Respiratory Diseases at the CDC. Continuing education information includes that to get CE credit, please go to http://www.cdc.gov/TCE online. The CE credit expires August 29th, 2016 for today's live program. For the Enduring Archive course, CE credit will expire June 1st of 2018. When obtaining CE, you will be required to provide a verification code. Please watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose we have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources for today's program, Varicella and Zoster, will be available at https://www.cdc.gov/vaccines/pb8.asp. If you have a question, please enter your question in the question and answer or QA pod you will see on your screen during the presentation. Let me now
Thank you, Dr. Strickus, and good afternoon, everyone. As Dr. Strickus mentioned earlier, today we will be discussing varicella and zoster diseases and vaccines. Varicella is commonly referred to as chickenpox. Zoster is called shingles. Varicella and zoster disease and vaccines are discussed in Chapter 22 of the 13th edition of the Epidemiology and Prevention of Vaccine-Preventable Diseases textbook, also known as the Pink Book. Chapter 22 begins on page 354 for those of you following along. Varicella zoster virus can be abbreviated VZV. VZV is a member of the herpes virus family. Other members include herpes simplex 1 and 2, cytomegalovirus, and Epstein-Barr virus. Varicella zoster virus shares with these viruses the capacity to persist in the body after primary infection and a tendency to recur. The primary or initial infection with VZV results in varicella or chickenpox. Recurrent infection results in herpes zoster or shingles. The virus is fragile and survives only a short time in the environment. Varicella zoster virus enters through the respiratory tract and conjunctiva. The virus is believed to replicate at the site of entry in the nasopharynx and regional lymph nodes. A primary viremia occurs 4 to 6 days after infection and disseminates the virus to other organs such as the liver, spleen, and sensory ganglia. Further replication occurs in the viscera following a secondary viremia with viral infection of the skin. Virus can be cultured from mononuclear cells of an infected person for 5 days before to 1 or 2 days after the appearance of the rash. A mild prodrome may precede the onset of a rash. Adults may have 1 to 2 days of fever and malaise prior to rash onset, but in children, the rash is often the first sign of disease. In individuals who have not been vaccinated with varicella vaccine, the rash is generalized and progresses rapidly, from macules to papules to vesicular lesions before crusting. The rash usually appears first on the head, then on the trunk, and then on the extremities. The highest concentration of lesions is on the trunk. Lesions also may occur on mucous membranes of the oral pharynx, respiratory tract, vagina, conjunctiva, and cornea. Lesions are usually 1 to 4 millimeters in diameter. The vesicles are superficial and delicate and contain clear fluid. They may erupt before they dry and crust. They may rupture before they dry and crust. Successive crops appear over several days with lesions present in several stages of development. For example, macular lesions may be observed in the same area of the skin as mature lesions. Healthy, unvaccinated children usually have between 200 to 500 lesions in 2 to 4 successive crops. Okay. Varicella is generally not a serious illness in healthy children, but can result in complications. Secondary bacterial infections of skin lesions are most common cause of hospitalization and outpatient medical visits. Pneumonia following varicella is usually viral, but may be bacterial. Secondary bacterial pneumonia is more common in children younger than 1 year of age. Central nervous system manifestations of varicella range from aseptic meningitis to encephalitis. Other complications include hemorrhagic, congenital, and perinatal varicella. In the pre-vaccine era, approximately 11,000 persons with varicella required hospitalization each year. Hospitalization rates were approximately 2 to 3 per 1,000 cases among healthy children and 8 per 1,000 cases among adults. Death occurred in approximately 1 in 60,000 cases. From 1990 to 1996, an average of 103 deaths from varicella were reported each year. Most deaths occurred in immunocompetent children and adults. Since 1996, hospitalization and death from varicella have declined to more than 70 to 88% respectively. This is a picture of secondary bacterial infection. This complication can be very severe or even fatal, particularly if group A streptococcus is involved. Some groups are at increased risk for complications of varicella. The risk of complications from varicella varies with age. Complications are infrequent among healthy children. They occur much more frequently in infants younger than 1 year of age and persons 15 years of age and older. Healthy adults are 25 times more likely to die from varicella than healthy children. Immunocompromised persons are at high risk of severe varicella disease. These people may have prolonged illness and an increased risk of complications. One of the highest risk groups is newborns of mothers with rash onset within 5 days before through 2 days after delivery. Varicella disease occurs worldwide. Varicella is a human disease. There are no animal or insect source or vector known to exist. As I mentioned earlier, varicella zoster virus infection occurs through the respiratory tract. The most common mode of transmission of VZV is believed to be person to person, from infected respiratory tract secretions. Transmission may also occur by respiratory contact with airborne droplets or by direct contact or inhalation of aerosols from vesicular fluid of the skin lesions. In the United States, incidence is highest between March and May and lowest between September and November. Herpes zoster has no seasonal variation and occurs throughout the year. The period of communicability extends from 1 to 2 days before rash onset until lesions have formed crust. Communicability may be longer in immunocompromised persons. Immunocompromised patients with varicella are probably contagious through the entire period new lesions are appearing. The virus has not been isolated from crusted lesions. Varicella is highly contagious. It is less contagious than measles, but more than mumps or rubella. Secondary attack rates among susceptible household contents of persons with varicella are as high as 90%. That means that 9 of 10 susceptible household contacts of persons with varicella may become infected. So now let's turn and look at herpes zoster or shingles. This occurs as a latent varicella zoster virus reactivates and causes recurrent disease. The immunologic mechanism that controls latency of VZV is not well understood. However, factors associated with recurrent disease include aging, immunosuppression, intrauterine exposure to VZV, and having had varicella at a young age, that is younger than 18 months of age. Life-threatening complications of zoster can occur. This includes dissemination with generalized skin eruptions and involvement of the central nervous system, lungs, liver, and pancreas. These are usually restricted to immunocompromised person. A feared consequence of zoster, particularly in older person, is postherpetic neuralgia or PHN. PHN is the persistence of sometimes debilitating pain weeks to many months after the resolution of the rash. Chronic pain from zoster can lead to insomnia, depression, and poor physical and social functioning. There is no consistently effective treatment for PHN. Approximately 15% of zoster cases involve the eye. This is called ophthalmic zoster and can lead to reduced vision or blindness. This is a woman with zoster involving the ophthalmic division of the trigeminal nerve and affecting the eye. An estimated 500,000 to 1 million episodes of zoster occur annually in the United States. The lifetime risk of zoster is estimated to be 32%. Increasing age and cellular immunosuppression are the most important risk factors. 50% of persons living until the age of 85 years will develop zoster. So now let's turn to the varicella-containing vaccines. There are 3 varicella-containing vaccines available in the United States. Single antigen varicella vaccine was licensed in the U.S. in 1995. Combination measles, mumps, rubella varicella vaccine called ProQuad was licensed in 2005 for children 12 months through 12 years of age. Zoster vaccine was licensed in 2006. All 3 vaccines contain the same live Okra-Merck varicella vaccine virus, but in different amounts. The concentration of virus is measured in plaque-forming units, abbreviated PFU. VariVax single antigen varicella vaccine contains about 1,400 PFU per dose. ProQuad contains about 7 times the virus in a dose of VariVax. Zostavax contains 14 times the concentration that is in VariVax. After 1 dose of single antigen varicella vaccine, 97% of children 12 months through 12 years of age develop detectable antibody titers. More than 90% of vaccine responders maintain antibody for at least 6 years. In Japanese studies, 97% of children had antibody 7 to 10 years after vaccination. Vaccine efficacy is estimated to be 70 to 90% against any infection and 90 to 100% against moderate to severe infection. Among healthy adolescents and adults 13 years of age and older, an average of 78% develop antibody after one dose and 99% develop antibody after a second dose, given 4 to 8 weeks later. Antibody persisted for at least 1 year in 90% of vaccinees who received a second dose. Immunity appears to be long-lasting and is probably permanent in the majority of vaccinees. MMRV vaccine, or ProQuad, was licensed on the basis of equivalence of immunogenicity of the antigenic components rather than clinical efficacy. Clinical studies involving healthy children aged 12 through 23 months indicated that those who received a single dose of MMRV vaccine developed similar levels of antibody to measles, mumps, rubella, and varicella as children who received MMR and varicella vaccine by separate injections. The primary clinical trial for Zoster vaccine included more than 38,000 adults 60 to 80 years of age with no prior history of shingles. Participants were followed for a median of 3.1 years after a single dose of vaccine. Compared with the placebo group, the vaccine group had 51% fewer episodes of Zoster. Efficacy was higher for persons 60 through 69 years of age at 64% and declined with increasing age. Efficacy was 18% for participants 80 years of age or older. Vaccine recipients who developed Zoster generally had less severe disease and about 66% less post-herpetic neuralgia, the pain associated with shingles that occurs after the rash has resolved. In a subsequent clinical trial that included more than 22,000 persons 50 through 59 years of age, Zoster vaccine was shown to reduce the risk of Zoster by 69.8% in this age group. The duration of the reduction of the risk of Zoster is not known. Varicella vaccine is routinely recommended for all children without contraindications at 12 through 15 months of age. A second dose of varicella vaccine should be administered at 4 to 6 years of age. The second dose may be administered earlier if at least 3 months have elapsed since the first dose. However, if the second dose is administered at least 28 days following the first dose, it does not need to be repeated. A second dose of varicella vaccine is also recommended for persons older than 6 years of age who may have received only one dose. So we encourage you to catch those children up. All varicella-containing vaccine should be administered by subcutaneous injection. Varicella vaccine is recommended for all adolescents and adults 13 years of age and older who do not have evidence of varicella immunity. Persons 13 years of age and older should receive 2 doses of varicella vaccines separated by at least 4 weeks. If there is a lapse of more than 4 weeks after the first dose, the second dose may be administered at any time without repeating the first dose. In 2011, ACIP published updated comprehensive recommendations for the protection of healthcare personnel against vaccine-preventable diseases. In this statement, ACIP recommends varicella vaccine for all healthcare personnel without evidence of immunity. Pre-vaccination serologic testing for varicella immunity of certain personnel is probably cost-effective. Healthcare facilities should develop policies that ensure that all healthcare personnel have evidence of immunity to varicella disease. Serologic screening should be considered for personnel who are uncertain of their varicella history or who report having had the disease. Post-vaccination testing for varicella immunity is not necessary or recommended because, remember, 99% of recipients are seropositive after that second dose. In fact, we strongly recommend you do not do serologic testing after vaccination. Most commercial antibody tests are not sensitive enough to detect antibody in some vaccinated persons. So post-vaccination testing can make life difficult because false negative results may make it appear that you have more susceptible persons in the facility than you actually have. So remember, we do not recommend serologic testing after vaccination. 2 doses of vaccine separated by at least 4 weeks should be administered to susceptible healthcare personnel. If a person So let's take a few minutes to talk about acceptable evidence of varicella immunity. If a person meets any of the criteria outlined on this slide for immunity, he or she can be considered immune to varicella and vaccination is not necessary. The first criterion is written documentation of age-appropriate vaccination. That would be 1 dose administered on or after the first birthday for preschool-age children and 2 doses for school-age children, adolescents, and adults. Second, a person born in the U.S. before 1980 can be considered to be immune, except for healthcare personnel and pregnant women. A higher standard of presumptive immunity is needed for these 2 groups. The third criterion is laboratory evidence of immunity or laboratory confirmation of varicella disease. Commercial assays can be used to assess disease-induced immunity. But remember, these assays lack sensitivity to always detect vaccine-induced immunity. As we discussed earlier, serologic testing after vaccination is not recommended. The fourth criterion is a healthcare provider diagnosis of varicella or verification of history of varicella disease. Verification means that a healthcare provider may retrospectively diagnose chickenpox based on the history provided by the patient or the parent. The last criterion for evidence of immunity is the history of herpes zoster or shingles based on healthcare provider diagnosis. A person needs to fit only one of these criteria to be considered immune to varicella. Anyone who fits none of them should be presumed to be susceptible and should be vaccinated. Additional details about these criteria for varicella immunity are in the 2007 varicella ACIP statement. So let's review recommendations for zoster vaccination. ACIP recommends a single dose of zoster vaccine for adults 60 years of age and older. The Food and Drug Administration has approved zoster vaccine for persons 50 years of age and older. When this happened, ACIP reviewed the burden of herpes zoster disease and the zoster vaccine licensure information. ACIP declined to vote to expand the recommendations for use of zoster vaccine to include persons 50 years of age and older. ACIP declined to vote to expand the recommendations for the use of zoster vaccine to include people 50 through 59 years of age for the following reasons. 1, age group. Though the burden of HZ disease increases after the age 50, disease rates are lower in this age group than they are in persons 60 years of age and older. There is insufficient evidence for long-term protection provided by the vaccine, and persons vaccinated at younger than 60 years may not be protected when the incidence of zoster and its complications are highest. Persons with a history of a prior episode of herpes zoster should be vaccinated. Also, persons with chronic medical conditions may be vaccinated unless they have a contraindication or precaution exists with that condition. ACIP zoster recommendation includes persons 60 years of age and older who are unsure or do not remember having chickenpox disease. Almost all of these persons have met the varicella immunity based on the ACIP definition of immunity. Screening potential zoster recipients for either history of chickenpox or serologic testing for varicella immunity is not necessary. Although most persons 60 years of age and older will test positive since they've had chickenpox, some will test negative. A negative screening test is more likely to indicate waning antibody level below the detection limit of the test rather than true susceptibility. Persons who are tested and found to be seronegative should receive 2 doses of single antigen varicella vaccine, not zoster vaccine. And it is also important to note here, zoster vaccine is not currently indicated or recommended for a person whose immunity to varicella is based on vaccination. The contraindications to varicella-containing vaccines are similar to those for other live attenuated virus vaccines. Persons with a severe allergic reaction, such as anaphylaxis, to a vaccine component or following a prior dose of varicella-containing vaccine should not receive varicella vaccine. Varicella, MMRV, and zoster vaccines all contain minute amounts of neomycin and hydrolyzed gelatin, but do not contain egg protein or preservatives. Pregnancy is also a contraindication to vaccination. Women known to be pregnant or attempting to become pregnant should not receive a varicella-containing vaccine. No adverse outcomes of pregnancy or in a fetus have been reported among women who were inadvertently received varicella vaccine shortly before or during pregnancy. Although the manufacturer package insert states otherwise, ACIP recommends that pregnancy be avoided for 1 month following the receipt of varicella vaccine. This is an off-label ACIP recommendation. Persons with immunosuppression due to leukemia, lymphoma, generalized malignancy, immune deficiency disease, or immunosuppressive therapy should not be vaccinated with varicella-containing vaccine. Most immunocompromised persons should not be vaccinated, but available data indicate that varicella vaccine is both effective and safe in persons with impaired humoral immunity. Humoral immunodeficiency alone is not considered to be a contraindication to varicella vaccine. ACIP recommends that you vaccinate persons with isolated humoral immunodeficiency. Rather, that the antibody products remember that the antibody products used to treat an isolated humoral immunodeficiency may interfere with the response to the vaccine. Recommended spacing between administration of the blood product and the receipt of varicella vaccine should be observed. Persons with moderate or severe cellular immunodeficiency resulting from infection with human immunodeficiency virus, HIV, including persons diagnosed with acquired immunodeficiency syndrome, AIDS, should not receive varicella vaccine. HIV-infected children with CD4 T lymphocyte counts of 15% or higher, older children and adults with a CD4 count of 200 per microliter or higher may be considered for vaccination. These persons may receive single antigen varicella vaccine, but should not be given MMRV or Proquad. As with other vaccines, moderate or severe acute illness is a precaution. Vaccination should be deferred until the acute illness has improved. This precaution is intended to prevent complicating the management of an ill patient with a potential vaccine adverse event such as a fever. Minor illness such as otitis media, an upper respiratory tract infection, concurrent antibiotic therapy, and exposure or recovery from other illnesses are not contraindications to varicella vaccination, although there is no evidence that either varicella or varicella vaccine exacerbates tuberculosis. Vaccination is not recommended for persons known to have untreated active tuberculosis. Tuberculosis skin testing is not a prerequisite for varicella vaccination. The effect of the administration of antibody-containing blood products, immune globulin, whole blood, or packed cells for some examples, on the response to varicella vaccine virus is unknown. Because of the potential inhibition of the response to varicella vaccination by passively transferred antibodies, varicella or MMRV vaccine should not be administered for 3 to 11 months after receipt of antibody-containing blood products. Receipt of blood products could interfere with the viral replication. The recommendation is to administer the vaccine at least 2 weeks prior to receiving blood products. And there is a table outlining this in the general recommendations. A personal or family, such as a sibling or a parent, history of seizures of any etiology is a precaution for MMRV vaccination. Studies suggest that children who have had a personal or family history of febrile seizures or a family history of epilepsy are at increased risk for febrile seizures compared with children without such histories. Children with a personal or family history of seizures of any etiology generally should be vaccinated with separate MMR and varicella vaccines because of the risk for using MMRV vaccine in this group of children generally outweighs the benefits. As with all other vaccines, a severe allergic reaction to a vaccine component following a prior dose is a contraindication to zoster vaccination. As with other live attenuated virus vaccines, pregnancy or planned pregnancy within 4 weeks, again, this is an ACIP off-label recommendation, and the immunosuppression are contraindications to zoster vaccination. We have received many questions about immunosuppression and zoster vaccine, so we can take a few minutes now to talk about it. Zoster vaccine should not be administered to persons with primary or acquired immunodeficiency. This includes persons with leukemia, lymphomas, or other malignant neoplasms affecting the bone marrow or the lymphatic system. The product information implies that zoster vaccine should not be administered to anyone who has ever had leukemia or lymphoma. However, ACIP recommends that persons whose leukemia or lymphoma is in remission and who have not received chemotherapy or radiation for at least 3 months can be vaccinated. And as noted on the bottom of the slide, this too is an ACIP off-label recommendation. Other immunosuppressive conditions that contraindicate zoster vaccine include AIDS or other clinical manifestations of HIV, including CD4 T lymphocyte values of less than 200 per mm or less than 15% of total lymphocytes. Persons receiving high-dose corticosteroid therapy should not be vaccinated. High-dose therapy is defined as 20 milligrams or more per day of prednisone or equivalent lasting 2 or more weeks. Zoster vaccination should be deferred for at least 1 month after discontinuation of therapy. As with other live attenuated viral vaccines, persons receiving lower doses of corticosteroids may be vaccinated. Topical, inhaled, or long-term alternate day treatment with low or moderate doses of short-acting systemic corticosteroids are not considered to be sufficiently immunosuppressive to contraindicate zoster vaccine. Low doses of drugs used for the treatment of rheumatoid arthritis, inflammatory bowel disease, and other conditions are also not considered sufficiently immunosuppressive to create safety concerns for zoster vaccine. Low-dose therapy with these drugs is not a contraindication for administration of zoster vaccine. The experience for hematopoietic stem cell transplant patient recipients with varicella-containing vaccine, including zoster vaccine, is limited. Physicians should assess the immune status of the recipient on a case-by-case basis to determine the relevant risks. If a decision is made to vaccinate with zoster vaccine, the vaccine should be administered at least 24 months after transplantation. The safety and efficacy of zoster vaccine administered concurrently with recombinant human immune mediators and immune modulators such as anti-tumor necrosis factor agents is not known. It is preferable to administer zoster vaccine before the treatment with these drugs. If it is not possible to administer zoster vaccine to patients before the initiation of treatment, physicians should assess the immune status of the recipient on a case-by-case basis to determine the relevant risks and benefits. Otherwise, vaccination with zoster vaccine should be deferred for at least 1 month after the discontinuation of treatment. As we've talked about earlier, moderate or severe acute illness is a precaution to vaccination. Current treatment with an antiviral drug active against herpes viruses is a precaution to vaccination. These drugs can interfere with the replication of the vaccine virus needed to produce immunity. Persons taking these drugs should discontinue them at least 24 hours before administration of zoster vaccine, and the drugs should not be taken for at least 14 days after vaccination. Unlike most other live attenuated virus vaccines, recent receipt of a blood product is not a precaution for zoster vaccine. Zoster vaccine can be administered at any time before, concurrent with, or after receiving blood or other antibody-containing products. Persons with a history of varicella are immune and generally maintain a high level of antibody to varicella zoster virus, a level comparable to that found in donated blood and antibody-containing blood products. Receiving an antibody-containing blood product will not change the amount of antibody in a person's blood. The most common adverse reaction is an injection site complaint, such as pain, swelling, or redness for both varicella and zoster vaccines. You might not have expected this from a live attenuated virus vaccine, but injection site complaints are reported in about 20% of the recipients receiving varicella vaccine and 34% of zoster vaccine recipients. 3 to 4% of varicella recipients developed a varicella-like rash at the site of injection. The rash may be macular-papular rather than vesicular, and it averages about 5 lesions. Systemic reactions after vaccination are not common. In MMRV, vaccine pre-licensure studies conducted among children 12 through 23 months of age, fever was observed 5 to 12 days after vaccination in 21.5% of MMRV vaccine recipients as compared with 14.9% of MMR vaccine and varicella vaccine recipients. 2 post-licensure studies indicated that among children 12 through 23 months of age, 1 additional febrile seizure occurred 5 to 12 days after vaccination per 2,300 to 2,600 children who had received the first dose of MMRV vaccine compared with children who received the first dose of MMR and varicella vaccine administered as separate injections at the same visit. Data from post-licensure studies do not suggest that children 4 to 6 years of age who received the second dose of MMRV vaccine had an increased risk for febrile seizures after vaccination compared with children the same age who received MMR vaccine and varicella vaccine administered as separate injections at the same visit. For the first dose of measles, mumps, rubella, and varicella containing vaccines given at 12 through 47 months of age, either separate MMR and varicella vaccines or MMRV vaccine may be used. However, providers considering using MMRV vaccine for children in this age group should take the time to talk with parents or caregivers about the benefits and risks associated with both vaccination options. Unless the parent or caregiver expresses a preference for MMRV vaccine, CDC recommends that MMR vaccine and varicella vaccine should be administered as separate injections for the first dose in children 12 through 47 months of age. Available data from post-licensure studies does not suggest that children aged 4 through 6 years who receive MMRV vaccine have an increased risk of febrile seizures after vaccination compared with same-age children who received MMR and varicella vaccines separately at the same visit. In addition, the second dose of MMRV vaccine is less likely to cause fever than the first dose. When the first dose of measles, mumps, rubella, and varicella vaccines is administered at 48 months or older, and for the second dose at any age, 15 months through 12 years, use of MMRV vaccine can be done. The combination vaccine is generally preferred over separate injections of MMR and varicella vaccine. Considerations should include provider assessment, including the number of injections, vaccine availability, likelihood of improved coverage, likelihood of patient return, storage and cost, patient preference, and the potential for adverse events. Varicella-containing vaccine should be stored frozen between -58 degrees Fahrenheit and +5 degrees Fahrenheit, or -50 Celsius and -15 Celsius in the original box with the lids on. The vaccine should be protected from light. Store diluent at room temperature or in the refrigerator. Do not freeze the diluent. Reconstitute the lyophilized vaccine just prior to administration using the diluent supplied by the manufacturer. Once prepared, the clock is ticking and the vaccine should be administered. Varicella and MMRV vaccine must be used within 30 minutes of reconstitution. Zoster vaccine must be reconstituted and used immediately upon removal from the freezer. Administer varicella-containing vaccines, varicella, MMRV, and Zoster via subcutaneous injection. Subcutaneous injections are administered into the fatty tissue found below the dermis and above muscle tissue. A 23 to 25 gauge 5/8 inch needle should be used. The recommended site when administering vaccine subcutaneously to persons 1 year of age and older is the upper outer triceps of the arm. If necessary, fatty tissue over the thigh may also be used. To avoid reaching the muscle, pinch up the fatty tissue, insert the needle at a 45-degree angle, and inject the vaccine into the tissue. An adhesive bandage may be applied to the site if bleeding occurs afterwards. Vaccine should be prepared and administered using aseptic technique. A new needle and syringe should be used for each injection. I'd like to thank you all now for listening for the last 40 minutes or so, and I would like to now turn the session back to Dr. Strickis for questions and answers.
Thank you very much, Ms. Walicki. I want to give you some continuing education information before we take the many questions we've received, or do as many as we can. The course code for today's program you see on your screen, I will read it to you, is capital WC 2645-072716, which is also the abbreviation for today's date. The verification code is ZOS for Zoster, ZOS-727. And the CE credit for today's live program expires August 29th, 2016. Again, instructions are available in the resource pod on the screen for you to access CE. I'll read that verification code one more time, and we'll leave the slide up. It is ZOS, ZOS-727. So let's go now to some of the many questions we've received today. Ms. Walicki, can we accept history of varicella as proof of immunity for healthcare personnel in our registry?
So one of the things I would recommend that you do is certainly contact your registry or your IIS system and determine what is the criteria that they use that can be that someone can put that into. Who can do that? So if it's if it's put in by a healthcare personnel or a doctor or whatever, I would then assume that yes, you could accept that as proof of disease, but I would certainly contact maybe your immunization program at your state health department for additional information or the IIS system.
Okay. The general evidence of immunity, I'll remind you, and you said this, is that persons who have a physician diagnosis or healthcare provider diagnosis of varicella can be counted, but it may be registry specific. There's a question here that if children less than 12 months of age are at increased risk of varicella complications, why is it we can't vaccinate those children as we do for measles?
Well, that's a really great question. And one of the things that you have to remember with a live attenuated vaccine is that it has to replicate for to produce the immunity that we would like to have, that we need to be protected. Children less than a year of age are in that unique position where they are recently born and they have there's that placental transfer of antibodies from the mother. So we want to wait and make sure that all maternal antibodies are gone so that they don't interfere with replication. So that's why we wait till a year or that's why the minimum age for the first dose of varicella is 1 year.
Okay, thank you. Here's a question again, healthcare personnel. We have an adult who received 1 dose of varicella vaccine, and that's documented. He or she thinks they received a 2nd dose but has no documentation. Should I do a titer before I give the dose I would give, which would be the 2nd documented dose, if they report a 2nd dose but don't have documentation, or is it simpler to just vaccinate that person?
So thank you so much for this question. This really brings up something that I like to always remind people is that verbal history of immunization does not count except for influenza and pneumococcal polysaccharide vaccine, and that's noted in the general recs. So if they verbally tell you that they had a dose but they have no documentation for it, you can't count that dose. With varicella, it's not going to be I would not recommend that you do any serology to determine if they received that 2nd dose, because as we noted earlier, that serology often is not sensitive enough to pick up vaccine-induced immunity. So what the recommendation would be just to go ahead and vaccinate and give a 2nd dose, and make sure that it's documented in the patient's record, in the immunization information system. If you can put adults into your immunization information systems, which most of the registries throughout the country you can now, and give them a record of it and tell them how important it is for them to keep a hold of their documentation.
Okay, thank you. You went over this, but I think it bears repeating. Can you say again why ProQuad MMRV vaccine should not be given, or is not recommended to be given, to young children to be receiving their 1st dose of MMR and varicella vaccine, but rather ideally is delayed to the 2nd dose?
That's a really great question. And there's, you know what, I'm so glad that you asked that, because I do want to highlight too that there are a lot of resources on the CDC webpage related to this that will be included on the resource document for varicella. But what you want to remember is that there's an increased risk of febrile seizure associated. There's an increased risk of fever, and there's an increased risk of febrile seizure with that 1st dose. And so that's why CDC recommends that as long as the parent does not prefer the MMRV after being told the pros and cons of both vaccination options, CDC prefers it for the first dose, and that in young children that the MMR and varicella vaccines be given separately.
Okay. Now, should a person who received 2 doses of varicella vaccine receive the Zoster vaccine when they turn 60? And a related question is there an increased risk of shingles for vaccinated people who receive varicella vaccine compared to people who didn't receive the vaccine but had natural disease or wild chickenpox?
Those are both really good questions. So let's take the first one. The first one is if a person has documented 2 doses of varicella, so their evidence of immunity is based on vaccination, you want to know, is Zoster vaccine recommended for that person when they turn 60? And it's not. Zoster vaccination is not recommended for persons whose immunity is from vaccination. And the second question was related to the incidence of zoster or shingles in children that are in persons who have received the vaccine, and it's thought to be less. So if they have not had chickenpox and had vaccine, their risk of zoster is less than somebody who's had chickenpox.
Okay, thank you. Here's sort of a 3-part question. They're all related. The questioner has a patient who's eligible, 60 years of age or older, for Zoster vaccine or shingles vaccine, who's going to be receiving chemotherapy soon. What are the guidelines for vaccination in that case where there's imminent immunosuppression? And then the related question is, if the person's presently receiving methotrexate and or steroids, can you vaccinate such a person?
So the guidelines related to persons who are immunosuppressed related to chemotherapy are outlined in the Zoster statement, and that's something that's very clear in the Zoster. It's very clear in the statement, so you certainly may want to go on the website and access that, and the resource page does have a link for that. So if you're talking about somebody who has had therapy right now related to leukemia, lymphomas, malignant neoplasms, or whatever, persons who have received therapy, Zoster vaccination is recommended for those who are in remission and who have not received chemotherapy or radiation for at least 3 months. So that's what the recommendations are in the ACIP statement.
But if someone's anticipating therapy in the future, how long should they wait after receiving Zoster vaccine and before they receive such immunosuppressive therapy, be it chemotherapy or steroids or something else?
You know, I would, for that question, I would encourage them to send that question to NIP info, because these are people that are going to be immune suppressed, and I would like to give them all the specific information.
Okay.
So send it to nipinfo@cdc.gov, put my name on it, Joellen Walicki, and I will send you back a response.
Okay, thank you. So a related question, a young child recently vaccinated with varicella vaccine, can that child possibly spread the infection, the vaccine virus infection, to other household members? The implication is there's an immunosuppressed person or a pregnant woman in the household. Is it okay to vaccinate that child, and what's the risk of spreading disease?
Oh, that's a really frequent question. So so the good news is that a child that's recently vaccinated is not going to be able to transmit will not transmit any infection, or is not at risk for transmitting anything respiratory. Actually, at that point, the child is more at risk of bringing chickenpox, wild chickenpox, in to the immune suppressed person from outside. So vaccinating is a really good idea. As I talked about earlier, there is a small number of people who develop a rash, and they could become, the immunosuppressed person, if exposed to the drainage from a vesicular rash, theoretically could be at risk. So if a child who lives with an immune suppressed person or a susceptible person develops a rash, certainly just put a bandage on it. Don't let the at-risk person change the bandage, and everything should be fine.
Okay, thank you. So I have a healthcare worker who doesn't have a history of varicella vaccination disease, but recently had a clinically diagnosed case of shingles by a healthcare provider. Does that person still need varicella vaccination?
No. Clinically diagnosed case of shingles by a healthcare provider is considered evidence of immunity.
Okay, so I think you'd covered this in detail, but are there any circumstances under which one would get varicella antibody titer after vaccination? And the second part is, well, I did a titer and it's negative and the person's had 2 doses of varicella vaccine. Do I repeat a dose of vaccination?
So there is no times where someone would recommend doing a titer after vaccination. There are no case scenarios or anything that I could think of why someone would want to do a titer after vaccination. Because the problem is oftentimes if you do a titer based on vaccine immunity, you are going to come back with a false negative statement or a false negative, and you're going to have people that you think that could potentially be susceptible. ACIP does not recommend vaccinating persons after doing a titer, regardless of the results.
Okay, thank you. Can you go over again the rationale for, there are many people who get shingles before the age of 60 years. The vaccine is licensed for people 50 and older. Why is it ACIP limits their recommendation to people 60 and older to receive shingles or Zoster vaccine?
So that's another frequent question. So the reason why is because there's a few reasons. One is that the greatest risk of the disease is persons age, and we don't know how long the vaccine is going to. We don't know how long the immunity is going to last. So we don't know if it's going to last up into the 60s, the 70s, and the 80s. The risk of severe disease is not in those persons 50 through 59 years of age. Certainly, the vaccine is licensed for that group and can be administered. But some of the things that I would mention to people is that it's not ACIP recommended in that age group, so the insurance company may or may not cover it, so that if you have somebody who comes in 50 to 59 who wants the vaccine, you're going to want to talk to them about the fact that it may not be covered by their insurance company and give them a heads up on the cost.
Okay, we'll do 2 more questions and wrap up. One of our listeners asked, can we use shingles or Zoster vaccine within 30 minutes of reconstitution? And for how many hours can the current vaccine be stored at refrigerator temperature?
Oh, I do not have that information with me offhand. The amount of time to storage, I forgot to print off the package insert, but that information is included in the package insert. And if you want to email me, I can send you the link, or I can send you the information.
Yeah, thank you. And I'll say this later, but we received more questions than we can answer. We will put in writing all the questions we received today and answers to them, 4 questions that are relevant to today's program, and every one I've seen had to do with today's program. So we will answer those in writing if we haven't had a chance to answer them now. Last question I'll ask you, then we'll wrap up. If a patient has a record of varicella vaccination, 2 doses, given before the age of 13 years, but they were less than 3 months apart, can that person be considered immune?
If there's at least 28 days between those 2 doses, you may accept both doses and no further doses are needed. Second dose is going to have to be repeated.
Thank you very much for your time, Ms. Willicke, and answering all those questions, and we'll address the other ones, as I said, online in the near future. So let me remind you of continuing education information, CE credit. Again, you go to http:// www.2a.cdc.gov/capital TCEO for online. Search for the live event course number, that is capital W, capital C, 2645-072716, today's date. CE credit for the live program expires August 29th of 2016. For the Enduring Archive course number, if you don't get to it before the live credit expires, that's course number capital W, capital D as in David, 2645-072716. CE credit for the Enduring program expires June 1st of 2018. And I'll say the verification code one more time, ZOS-727. That's capital Z, lowercase os-727. For help with the online CE system, which usually works very well and is easy to use, which you may call between the hours of 8 a.m. and 4 p.m. Eastern Time, 1-800-41-TRAIN, or email to cdc@cdc.gov. Email your immunization questions if you need them answered urgently about today's program and indicate it was from today's program to nipinfo@cdc.gov, and we'll address those as quickly as we can. But we will address all the questions received in the near future and put them as a resource on our website. If you have general immunization questions, you may call 1-800-CDC-INFO. between 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources are the Pink Book, or Epidemiology Prevention of Vaccine-Preventable Diseases, published last year, 2015. The website for the Pink Book is there. If you go to CDC's website and just enter in the search screen Pink Book, you'll find it. Our homepage for vaccines is cdc.gov/vaccines/default.htm. And there are abundant immunization resources for you and your patients that will point to specific resources for today's program and post those shortly. But the general page for resources, cdc.gov/vaccines/ed/downloads/imz-resources.pdf. And our Twitter handle is @CDCIZLearn. And thank you for listening to today's program. We look forward to seeing you next week to continue the series. And thank you very much from Atlanta.